And I'm very, very pleased to introduce our speaker today. You may have already encountered him in the hall or on a consult or somewhere along the way, but we are, on behalf of the entire division, really happy to introduce Dr. Kieron Dunleavy. He has joined us to lead our malignant hematology program. He is a professor of medicine, and his education journey starts in Dublin, Ireland, where he did the bulk of his basic training, if you will, and then came to the DC area and to the NIH, where he did fellowship and stayed on faculty to take leadership role in lymphoma there as well. Then briefly at GW, where we were very pleased to steal him over the last year or so, and he's graciously come to our team to really be transformative in our world of heme malignancies. His particular interest is in lymphomas and a variety of spectrum of those. He's published nearly 150, over 130 publications out there in this space. And so recognized as a global leader in this. And we are really lucky to have him. And with that introduction, Dr. Dunleavy, this is the Department of Medicine. It's where I cut my teeth and grew up. And Thursday Grand Rounds is a long tradition. So we're all delighted that you have joined to share your insights on the insights into lymphomas.
Okay, thanks very much, John, for the kind introduction. And I'm very happy to be here and to be invited to present at Grand Rounds. I realize that the audience is probably predominantly internal medicine, so I hope that some of the things that I talk about are not too complex and can be broadly interpreted. So I'm really going to focus for the next hour on aggressive B-cell lymphoma and talk about some of the advances that have been made over recent years and where we are right now and what lies ahead. So in terms of lymphomas, 85% of lymphomas are B-cell lymphomas, 15% are T-cell. Aggressive B-cell lymphoma is the most common type of lymphoma, and despite us, putting a huge amount of effort into improving therapeutics and doing really good clinical trials, about 30% of patients with this disease are not curable with upfront therapy. These types of lymphomas are very much, you have one opportunity to cure them. It's very difficult to cure people if aggressive lymphoma comes back. It's possible to do that, but the percentage of patients who are cured if their disease relapses is very, very low. So the big challenge in this disease is to identify the incurable proportion, because as I'll talk about, we have spent a lot of time trying to figure out who that 30% are, but we're still not there yet. We've got pretty good at using clinical characteristics to identify people who might not do as well, but we still have a long way to go with the biological characteristics, although we've made a lot of progress recently. And then we have to understand reasons for treatment failure. Why do certain tumor biologies fail first-line treatment, and how do we prevent that from happening in the future? And then we have to, with these two things, figure out strategies that overcome this. This just shows you the most common type of non-Hodgkin lymphomas. Lymphomas are very complicated. There are over 100 different types of lymphomas, and the ones that I'm going to focus on during this talk are diffuse large B-cell lymphoma, which is the most common. It's probably actually closer to 40%, and also Burkitt lymphoma and primary mediastinal B-cell lymphoma, which, especially when I was at NIH, I spent a lot of time focusing on those two types and continue to work on projects with others around the country as we try to advance the therapeutics for patients with those diseases. So really with lymphoma, I would say of all cancers, or it's certainly up there, pathology is really, really important. And when we see new patients in clinic, we are very reliant on what the pathologist says, and it's a really critical part of our interaction with the patient, talking about pathology, and not just the exact diagnosis, but there are lots of nuances, and they're all really starting to have clinical relevance now, and they certainly have relevance in terms of how we think about the tumor and the prognosis. So our interaction with pathology is very important. And this is a H&E, this of a patient with diffuse large B-cell lymphoma. This is just showing you the cells morphologically. And we have got immunohistochemistry, which is very helpful, obviously telling you if a lymphoma is B-cell or T-cell, if you look at CD20 and look at T-cell markers like CD3 and CD5. And then we have a spate of other markers. But, even with all of this, diffuse large B-cell lymphoma is very complicated. And about 20 years ago, there's a group called the Lymphoma and Leukemia Molecular Profiling Project. They looked at hundreds of samples of diffuse large B-cell lymphoma, and they applied gene expression profiling to those lymphomas. So they looked at the differential expression of tens of thousands of genes. And what they were able to show was that diffuse large B-cell lymphoma was not just one disease, but was actually several diseases. But they were able to divide most cases into two different subtypes. One was called an activated B-cell subtype, and the other was a germinal center B-cell subtype. And these subtypes correspond to different stages of B-cell differentiation. And this was an enormous advance. It's definitely not a perfect story. There are a lot of there's a lot of work that has to be done with this, and over the past few years, this initial definition has been refined quite significantly. But it's been really helpful in terms of allowing us to have a biological the platform to predict how people will do, and then as we're using more and more new therapies and new types of treatments like CAR T cells and bispecific antibodies, understanding that people fit into different molecular biologies is really important in terms of predicting who might respond to whichever therapy. And that's actually really starting to become important in certain patients, even in the front line when we're selecting therapy for them. Just broadly, if you have diffuse large B-cell lymphoma, if you have the ABC subtype, you have a much worse outcome. So this is a Kaplan-Meier curve from a study that was done in British Columbia. They looked at over 300 patients with diffuse large B-cell lymphoma. As you can see here, the follow-up is very long, but there's a significant progression-free survival difference between the ABC subtype and the GCB subtype. So the ABC subtype does much worse. It's really kind of interesting when you look into this more. So if you look at people of all ages with diffuse large B-cell lymphoma, you almost never see the ABC subtype in children or adolescents with the disease. But as people get older, the proportion who have the ABC subtype goes up. So if you look at people, for example, between 50 and 60, it's about 20%. But if you look at people over 80, it's over 50%. And it's also interesting when talking about that to look at other genomic aberrations in diffuse large B-cell lymphoma as people get older. And if you look at all of these various aberrations, translocations, increased copy numbers, et cetera, you see that people who are very, very young, so when we look at pediatrics, they have a very low proportion of these genomic aberrations. But as people age, their tumors have a much higher proportion of these. And this is starting to become important because a lot of these aberrations are targetable with new therapies. So it's turning out that not only are there molecular subtypes in the disease overall, but as people age, they really have a different profile of the disease. And when we think about personalized therapy and tailoring therapy, that also may be something that is age specific to some degree, which I think is really interesting. This is a really interesting slide, I think. This was a large study called the ROBUST study, which looked at newly diagnosed patients with diffuse large B-cell lymphoma. They got the standard treatment, which is R-CHOP, or they got R-CHOP with a drug called lenalidomide, which is an immunomodulatory drug. I think why this slide is so interesting is that in selecting patients for this study, there were people sampled all over the world with diffuse large B-cell lymphoma. And this shows you the breakdown of ABC and non-ABC, so these molecular profiles that I talked about, and there's significant regional variation. So if you look at the proportions in Asia compared to North America and Europe, they're very, very different. And moving beyond diffuse large B-cell lymphoma and lymphomas, it's really interesting because there are certain types of lymphomas that you simply do not see in certain parts of the world. In parts of Asia, for example, you see very, very little CLL and SLL, chronic lymphocytic leukemia, and small lymphocytic lymphoma. So I think that this is interesting, and we could really have a whole discussion about this. And does that point to different types of environmental factors? Viruses, can they be, have they got a much bigger role in lymphomagenesis than we appreciate right now? So these are very interesting questions, but I think that this is an interesting slide. So the ABC and the GCB, they're different biologically, and as I said, they're really completely different tumors. So one comes from a germinal center B cell, the other comes from a plasmablast that's blocked during plasmacytic differentiation. And if you look at their mechanisms of oncogenic activation, they're completely different. So the GCB subtype, they frequently have a BCL2 translocation or a MYC translocation, whereas the ABC subtype have got activation of a pathway which is really common in cancers, not just in lymphoma, called the NF-kappa B pathway. And you don't see activation of that pathway in the GCB subtype. About 15 years ago, when I was when I was a fellow at the NCI, we were really interested in targeting the ABC subtype because patients who had it did worse. They had a worse outcome. And we hypothesized that if we added a drug that specifically targeted this subtype, that could improve in outcome for patients with the disease. So back then, we started using a drug called bortezomib, which is used in multiple myeloma quite frequently. It's a very broad inhibitor of NF-kappa B, and it really was the only drug that we had back then that targeted the ABC pathway. And we did a study, and we included patients with GCB and with ABC, and our findings were not completely clear-cut, but we did show that there was selective activity of bortezomib in the ABC subtype. Then, following on from that, there was a large UK study where over 1,000 patients were treated, and they treated these patients with the standard treatment, R-CHOP, or R-CHOP with bortezomib. But unfortunately, they didn't find that there was any survival advantage when you added in bortezomib, and there was a lot more toxicity, and this is especially a very neurotoxic drug. After we had started our study, and another drug which I'm sure you're familiar with, because after rituximab, I think at this point in time, it's the most commonly used drug in lymphoma, and that's ibrutinib. And ibrutinib is an inhibitor of Bruton's tyrosine kinase. And in the ABC subtype, BTK is a very important enzyme in NF-kappa B activation. So this was a study that was done in relapsed and refractory diffuse large B-cell lymphoma. These patients, they just got single agent ibrutinib, and it was really interesting because, as you might have expected, ibrutinib, in terms of how we understand how it works, it's selective for the ABC subtype, and this is exactly what this clinical study showed, as you can see here. Patients who had the ABC subtype had a response rate of 40%, and only one patient with the GCB subtype had a response rate. So this was really interesting, and I'm not going to show it here, but also as part of this study, there was a mutational profile done on a proportion of patients. So their tumors were surveyed for certain mutations that are common in the ABC subtype and that are critical in activating NF-kappa B. And there was a correlation between those mutations, between having those mutations and response to ibrutinib. So this was not a game changer type of drug. I mean, these patients responded for a very brief period of time. And if you look at their progression-free survival to see how they did over several months, it wasn't very long. The median progression-free survival was between 3 and 4 months. But in terms of a proof of concept, it showed that you could target NF-kappa B and selectively improve the outcome for those people with the ABC. So moving a little bit laterally, primary CNS lymphoma is an unusual type of lymphoma. It is usually EBV negative. In people with HIV, they have a higher risk of getting primary CNS lymphoma, and it's almost always HIV positive. And we now understand that biologically it's a different disease. And when it's encountered in HIV negative people, almost all the cases are diffuse large B-cell lymphoma. But it's a really different type of lymphoma to systemic diffuse large B-cell lymphoma, and it has a lot of the characteristics that ABC systemic lymphoma has. But it's really interesting because if you look at some of these key mutations that we can identify in systemic ABC lymphoma, they are much, much higher in primary CNS lymphoma. So, two mutations that we look at quite a lot are MIghty88 and CD79B. The MIghty88 mutation is found in about 20% of systemic ABC lymphomas, but it's found in about 70 or 80% of primary CNS lymphomas. And we did, a few years ago, we did a study, this is part of the study, but using ibrutinib in patients with this disease. Most of the patients on this study had relapsed or refractory disease, and some had untreated disease. But it was really remarkable how this drug worked in these patients. And at the time that we did our study, there were 2 other groups that also were studying ibrutinib in primary CNS lymphoma, and all showed these dramatic responses. And for the most part, these were people who had had 3-4 lines of treatment before. A lot of them had received cranial radiation. And after 14 days of the drug, they had really good responses as shown here. But again, these responses didn't last for a very long time. If you look at people 3 and 4 months after they have been on this drug, the vast majority of them have relapsed. This was one patient, and this is just with single agent ibrutinib, who had a number of different lines of therapy, and after 14 days of ibrutinib had a very impressive response. So I'm not going to talk about primary CNS lymphoma, but I'm just trying to really put that together with our understanding of systemic lymphomas and just highlight how we need to use what we identify in some lymphomas to inform us about others, and then therapeutically to move in with agents that we have shown selective activity in a particular type of lymphoma, and if we can understand the biology of that, and if there are other lymphomas that have similar biology, then we can test similar strategies in those lymphomas. And the whole therapeutic landscape of primary CNS lymphoma is really changing rapidly, not just with BTK inhibitors, but it turns out that it's a very sensitive tumor to a lot of novel targeted therapies, and the upfront treatment that we have at this point in time is not very good. We usually give people high-dose methotrexate and cytarabine, which are not particularly good drugs for lymphoma, but they penetrate the CNS. So we're really at a very exciting time with that disease. Coming back to systemic diffuse large B-cell lymphoma, we've really spent 15 years targeting the ABC subtype with a number of different agents. And over the last year, there were 2 large randomized studies presented. One of them looked at adding ibrutinib to R-CHOP, and the other one looked at adding lenalidomide to R-CHOP. And both of the studies were negative, but there were some interesting findings. And the study that used ibrutinib Again, all the patients on that study had the non-GCB subtype. And while there wasn't an overall benefit to adding it, there was a benefit in younger people. And it's controversial what that means. But one of the big companies has moved forward and is in the middle of doing another large study in newly diagnosed people, adding a different type of BTK inhibitor, with the thinking that there was a signal in that previous study. So that's where we are with that. But all of the other studies that have been done, unfortunately, they've not shown a benefit. So at this point in time, R-CHOP is still the standard treatment, and also for the ABC subtype, we've not been able to really take advantage of our insights into the molecular biology of the disease to make a significant difference in upfront therapeutics. But I think we're very close to doing that, and there are a number of studies that are ongoing at the moment. These are some of the studies that are currently ongoing for newly diagnosed patients with diffuse large B-cell lymphoma. And of these studies, one that has got a lot of press over the last 2 months is a study that's using an antibody drug conjugate against CD79B called polatuzumab. And this study compares polatuzumab with CHP. The O is vincristine, and that's taken out, and compares that to R-CHOP. And that the company who make polatuzumab have just released initial results of the study and said that it was a positive study and it met its primary endpoint of improving progression-free survival. So the results of this study have not been made available yet, but if it did reach its endpoint, and this particular drug is not specific for cell of origin, so we don't have any evidence that it works better in GCB or non-GCB. So that will be very interesting when the data is made available. And this potentially could be a huge game changer in terms of how we treat people with diffuse large B-cell lymphoma, if there is a significant survival advantage to getting polatuzumab. So that's cell of origin. As I said, this area is complicated, but the biology of large cell is very much kind of at the front of us thinking about how to treat people. So putting cell of origin aside a little bit, a number of years ago, there were several publications that showed that if you had a translocation of MYC and a translocation of BCL2, so-called double hit lymphoma, that you had a much worse outcome with standard treatment. So with standard treatment, about 70% of people are cured, but this first study and several subsequent studies showed that if you had double hit lymphoma, your cure rate was about 35%. So that led to a huge focus in our field on MYC and BCL2 rearrangements, trying to better understand what that means biologically, and then starting clinical trials to improve outcome. Because if you look at a group overall where you have a 70% cure rate, if you have a significant subset of that group that have a 30% cure rate, there is obviously a real need to make a big difference and figure out what is needed to improve outcome in these patients. So there's a lot of emphasis on double hit and double expressor lymphomas. Just to summarize this in a somewhat simplistic way, about 10% of diffuse large B-cell lymphomas have got a MYC rearrangement, and these are almost always of GCB origin. A lot more diffuse large B-cell lymphomas have got high MYC expression, but if you look at those with high MYC expression, if they do not have a MYC rearrangement, then those are usually of ABC origin. About 30% of diffuse large B-cell lymphomas have got a BCL2 rearrangement, and again, these are almost always of GCB origin, whereas cases that have got high BCL2 expression that do not have a rearrangement are of ABC origin. So when we talk about double hit and double expressor lymphomas. Double hit lymphomas have got a MYC and a BCL2 rearrangement, and they're almost always of GCB origin. And double expressor lymphomas without any rearrangements are almost always of ABC origin. And this is really important as we figure out where novel therapies go, especially when they have selective or when they have already demonstrated selective activity in one of these subtypes, obviously. And there is a third group of lymphomas that have a BCL6 rearrangement, and these are usually of ABC origin, and it's not as clear what that means. There's a lot of debate at the moment about the outcome of double hits that have got a BCL2 and a BCL6 rearrangement, or a MYC and a BCL6 rearrangement, and those don't tend to do as poorly as people who have got a MYC and a BCL2 rearrangement. And this whole area is changing rapidly. Over the last year, there has been a lot of work looking at something called a double hit signature, which is very common in the GCB subtype, and a lot of tumors that have a double hit signature do not have the rearrangements, and those people prognostically do not do well. So it's a very interesting area, but I think that it's not been very well put together in terms of correlating these rearrangements or high expression of these proteins with other markers and also with some clinical characteristics. So that's where the field is in terms of trying to better target these tumors as they have a much worse outcome. This was a study that we did looking at dose-adjusted epoch R in high-grade B-cell lymphomas with a MYC rearrangement, and about half of these had double hit. And this was a single-arm study, but the results here are good in terms of this population of patients usually have a survival rate of 35%. So this was a multi-center study, and the progression-free survival was approximately 70%. Sorry, so this just shows you how we approach aggressive B-cell lymphoma. So diffuse large B-cell lymphoma is now completely separated from high-grade B-cell lymphoma. And when we see high-grade B-cell lymphoma, a certain proportion of these have got a double hit or a triple hit morphology and genetically also. And some of them are called NOS, not otherwise specified. And these are almost always GCB tumors. And as opposed to using R-CHOP in most of these cases, we tend to use intensive regimens or consider patients for clinical trials. So, moving forward to some of the new therapies that are available and that are being tested. So you probably have heard quite a bit about anti-CD19 CAR T cells. So a few years ago, the initial work was done at the NIH by Jim Kokendorfer, and they developed a CAR T cell which targeted CD19, which is expressed on B-cell lymphomas and almost all B-cell lymphomas. So they tested anti-CD19 CAR T cells in patients with relapsed and refractory diffuse large B-cell lymphoma, and these people had at least 2 lines of treatment before. And what they found in this initial study was that about 40% of people who received CAR T cells in at least the 3rd line of treatment had a very good response, and the cure rate was 40%. So this led to several companies commercializing CAR T cells. The first of these was Kite, and there was a large study called the Zuma-1 study done. And subsequently, there were 2 other studies called the Juliet study and the Transcend NHL study. Now there are several CAR T cell products FDA approved for patients with relapsed and refractory diffuse large B-cell lymphoma. And a number of these are already actually being tested in the upfront setting in patients with poor clinical risk factors and poor biological factors. So this is a very interesting advancement, and this is something that we are doing here with Dr. Munchie and Dr. Rowley and Dr. Allah, who recently joined the transplant group. So shown here are a number of new approaches in diffuse large B-cell lymphoma, including CD19 CAR T cells. So there, as you can see, there are a number of strategies in development. This is a picture taken from an editorial that Dr. Cook wrote. He's one of our second year fellows. But you can see here that there are a lot of interesting strategies for diffuse large B-cell lymphoma. So as well as CAR T cells, the other group of drugs that are showing very good efficacy in the relapsed and refractory setting are bispecific antibodies. And the bispecific antibodies that have been most studied in diffuse large B-cell lymphoma, they target a B cell and a T cell. So they target CD20 on the B cell and CD3 on the T cell. These are not FDA approved yet, but several of them have been in clinical trials that are completed, and some of them have been published over the last few months. So these are very interesting agents, and it'll be interesting to see where they go. And then there are a number of other antigens on B cells that can be targeted. In terms of immune checkpoint inhibitors, I'm not going to talk about Hodgkin lymphoma, but in Hodgkin lymphoma, these agents are very, very effective. They're not as effective in diffuse large B-cell lymphoma. The response rate is less than 10%. But there are some new strategies that are incorporating them in somewhat non-conventional ways, in terms of there's a priming strategy that's being looked at where people get immune checkpoint inhibitors before they get immunochemotherapy. And there certainly is some activity of these agents, but not as much as in some other lymphomas. And then, as I talked about earlier, polatuzumab, which targets CD79B, is shown here. And that, as I told you in the Polaric study, is combined with RCHP, and initial results say that the study was positive. These are the first CAR T cell studies, which I just mentioned, and these are the pivotal CAR T cell trials. In the relapsed and refractory setting, there are now a number of studies that are close to completion or have been completed that have looked at auto transplants compared to CAR T cells in people who have a first relapse of diffuse large B-cell lymphoma. And again, we don't have full results of these studies, but two of these studies, according to the companies, have shown positive results and have met their endpoints, and one has not. And this is really interesting. This has just happened over the last month or 6 weeks. And the question is, when people with diffuse large B-cell lymphoma, when their disease comes back, our typical strategy is to move to autologous stem cell transplant. But if we have CAR T cell studies that show an advantage to CAR T cell over auto transplant, then the question is if our sequencing of therapies in diffuse large B-cell lymphoma will completely change. So at this point, we don't know if this will happen, but I think over the next few months, it's going to be interesting to see the full results of these randomized studies, the early results of which we have. This is one of the bispecific studies that looked at a bispecific antibody called glofitamab in patients with relapsed and refractory, mainly diffuse large B-cell lymphoma and follicular lymphoma. This agent was associated with very good responses, again, in a population of patients who had been heavily pretreated. So, next I'm just going to talk about B-cell lymphomas in the AYA population, who are adolescents and young adults. We have a pediatric oncology group here, and they're very interested in these lymphomas, as I am as well. So I think that we have a lot of room for collaboration and for doing studies together in the future. So the types of B-cell lymphomas that you see in the AYA population are very distinct. Diffuse large B-cell lymphoma does occur, but nothing like the frequency that it occurs in older adults. The median age of diagnosis is 67, but you do see younger people with the disease. But most of the lymphomas that we see in the AYA population, and these are people from the age of 15 to 35, are primary mediastinal B-cell lymphoma and Burkitt lymphoma. And I'm just going to talk about primary mediastinal B-cell lymphoma for a few minutes. So, when the initial work was done looking at cell of origin and dividing out diffuse large B-cell lymphoma, diffuse large B-cell lymphoma used to be considered as, considered to include primary mediastinal B-cell lymphoma as well as the GCB and ABC subtypes. But our understanding of it has really been refined over the past 10 or 15 years, and we now understand it to be a completely distinct clinico-pathologic entity. And that really makes sense clinically because the vast majority of patients with primary mediastinal B-cell lymphoma are females. They almost always present with a large mediastinal mass. They often have a pericardial effusion or a pleural effusion. We now understand that the disease originates from the thymus. So the cell of origin is a thymic B cell. And nodular sclerosing Hodgkin lymphoma, which is the most common type of Hodgkin lymphoma, also typically affects young women between the ages of 15 and 35. And it also is thought to arise from the thymus gland. And if you look at gene expression profiling, primary mediastinal B-cell lymphoma, which is shown here on the left, is very similar to Hodgkin lymphoma and completely different to diffuse large B-cell lymphoma. So we've really moved from considering primary mediastinal B-cell lymphoma to be a type of diffuse large B-cell lymphoma to now recognizing it as a distinct entity. And I think that that's important in terms of thinking about how to treat it. And we now understand that there exists a spectrum of mediastinal lymphomas. So on the left here is nodular sclerosing Hodgkin lymphoma with a Reed-Sternberg cell, and on the right is primary mediastinal B-cell lymphoma. And clinically, these can be quite difficult to distinguish because they have very similar clinical presentations. Typically, it's a young woman presenting with a large mediastinal mass. And it's very challenging to diagnose these patients because they are, for the most part, diagnosed by a CT-guided core biopsy. And of course, that doesn't allow you to get a huge amount of tissue. And one thing about Hodgkin lymphoma is that there are very few tumor cells. So it's really challenging for the pathologist to make a diagnosis of Hodgkin lymphoma with a very small amount of tissue. It's a little bit easier with primary mediastinal B-cell lymphoma, but clinically, we're often in a situation where we have a young patient who has a huge mediastinal mass, and it's probably one of these two things, and we make the diagnosis based on a core biopsy. But we have to be certain, obviously, that it is lymphoma and that it does fit into one of these two types of lymphomas. There are lymphomas that are in between NS Hodgkin lymphoma and primary mediastinal B-cell lymphoma, and these are called mediastinal gray zone lymphomas, and they have features, as the name suggests, in between NSHL and primary mediastinal B-cell lymphoma. And it's helpful to do immunohistochemistry to differentiate these two types of lymphomas. Hodgkin lymphoma is CD30 positive and almost always CD15 positive and CD20 negative. And primary mediastinal is CD15 negative and CD30 weakly positive and CD20 positive. But the gray zone lymphomas often have immunohistochemical profiles that do not fit into these boxes. And it's really interesting that the gray zone lymphomas usually occur in males compared to the other two types that usually occur in females. So what about the treatment of primary mediastinal B-cell lymphoma? So, as I've told you over the last few minutes, it is a distinct entity. It affects young women for the most part. It's a highly curable lymphoma. And over the years, the typical way that it has been treated has been with chemotherapy, and most recently with immunochemotherapy, followed by mediastinal radiation treatment. These are a number of studies that have been done over the last 15 years. These are people with newly diagnosed primary mediastinal B-cell lymphoma. And as you can see here from the column in the middle, the vast majority of patients on these studies received mediastinal radiation. And that's, potentially a real problem in these patients because they're very young. They have a high cure rate. So after they finish their lymphoma therapy, the vast majority of them never need to get any more therapy for their lymphoma, and they hopefully live normal lives and have an average life expectancy. But we now know that if you have mediastinal radiation, it's associated with significant long-term toxicities. Over the last few years, there have been a lot of cohort studies that have looked at the long-term effects of mediastinal radiation. There was one study in particular, which was a childhood cohort study that looked at a few thousand children and adolescents who had received mediastinal radiation 20, 30, 40 years ago. And in females, if you look at the incidence of breast cancer, 10 years and beyond, it's in the region of 20%. Now, I think that we have got much better at administering radiation, and the whole field has entirely changed. I guess we'll not be able to see the improvements or the reduction in long-term toxicities with current radiation strategies for some time, because it's only an endpoint that you can look at longitudinally as you have a lot of follow-up of patients. But in this particular type of lymphoma, we really have been making efforts to take radiation out of the equation because of its long-term toxicities. And this is something that we have done with dose-adjusted epoch-R. So we initially did a study of 53 patients, and their progression-free survival was 97% without radiation treatment. And subsequent to that study, there have been two other studies. One of them is a long-term follow-up of the initial study with 100 patients. And then the other study is a multi-center study in the US that looked at both pediatrics and adults with primary mediastinal lymphoma who got the regimen, and there were 150 patients on that study. And again, 15% of patients on the study on the right got radiation treatment. So these showed that you could avoid radiation treatment if you use dose-adjusted epoch-R in the vast majority of people. And this is very important, obviously, to reduce long-term side effects for this patient population. So I talked about immune checkpoint inhibitors, and this is a disease where, as you might expect, they have good activity because primary mediastinal lymphoma is very close biologically to Hodgkin lymphoma, where immune checkpoint inhibitors are very effective. And pembrolizumab is FDA approved for patients with relapsed and refractory primary mediastinal B-cell lymphoma based on these studies. And a study that I'm involved with, I'm the ECOG chair for this study, is a sort of a unique study because it's a study that is it's just opened, and it's taking place in both pediatrics and adults. So it's being run by the Children's Oncology Group as well as the adult NCI cooperative groups. And this study is going to treat people with newly diagnosed primary mediastinal B-cell lymphoma and randomize them to receive nivolumab or not, to see if there is a benefit to adding immune checkpoint inhibitors in the upfront setting for patients with this disease. Just going to briefly talk about Burkitt lymphoma, and that's a very rare lymphoma. It's much more common in people who are HIV positive. It's associated with EBV. The percentage association with EBV is different depending on the type. Endemic Burkitt occurs in equatorial Africa and other regions of the world where it's 100% EBV positive. Sporadic, which is the major type that we see in the US, is associated with EBV in about 30 to 40%, as is HIV-associated Burkitt or Burkitt lymphoma. And the hallmark translocation in Burkitt lymphoma is a c-MYC translocation. And you see that in all patients with the disease. And when we have new patients with Burkitt lymphoma, we typically use very intensive regimens. We use usually one of two regimens. One is called Codox-M-IVAC with rituximab, and the other is called Hyper-CVAD with rituximab. And Codox-M-IVAC was developed at the NCI by Ian McGrath, who was an oncologist there about 30 years ago. And he did a study in both children and adults with Burkitt lymphoma and showed very good results. And a lot of the idea behind Codox-M-IVAC really came from studies in aggressive leukemias, and a lot of the strategy was really a modification from what the early studies in leukemias had done. But the regimen is very toxic. It's effective, and young people tolerate it, but older people have a real problem tolerating it. And if you look at people over the age of 40, they have significant complications with it. And one of the big challenges in giving it to older people is that Burkitt lymphoma is characterized by a very high proliferation rate, and the early cycles are really important. And if you give older people very intensive regimens, you sometimes are not able to come in with the second cycle of treatment. And the last thing you want to do with Burkitt lymphoma is let the disease grow in between cycles. But if you have older people who just aren't able to tolerate it and their counts don't recover for some time, that can really be a problem, and they may not be able to get the second cycle on time, which can be detrimental to their curability. So again, we did a small study with EPOCH-OR in Burkitt lymphoma. We treated 30 patients. That was published back in 2013. And then we did a multi-center study across the US. We treated over 100 patients with newly diagnosed Burkitt lymphoma, and we divided those into high risk and low risk. And the results were published last year, and the results were excellent and very comparable with Codox-M-IVAC or Hyper-CVAD historical results. There was one group of patients who did not do well, and they were people who had CNS disease at diagnosis. But really, if you look at any of the other regimens, that subset of patients don't do well. And there's now an ongoing randomized study, which is led by a group in the Netherlands, the Hoven group, and they're comparing EPOCH-OR to Codox-M-IVAC with rituximab in people with newly diagnosed Burkitt lymphoma. Just to finish, I'm just going to talk about a few important concepts in lymphoma that are very much at the front of ideas in terms of developing new strategies and are really close to coming to the clinic in a standard way. Just like other tumors, we have made a lot of advances in looking at MRD in B-cell lymphoma. There now are a number of studies that have looked at circulating tumor DNA, and a number of studies that are ongoing that have incorporated circulating tumor DNA assays prospectively. But retrospectively, this was one study that was done at the NCI. This study looked at over 100 patients, and they all had circulating tumor DNA checked during their immunochemotherapy. They all had diffuse large B-cell lymphoma. And you can see here, these are their cycles of treatment, and with cycles of treatment, the volume of circulating tumor DNA comes down significantly. I should say that this assay that has been most developed in B-cell lymphomas looks at the VDJ sequence. which is unique to every lymphoma. And then this can be amplified, and if the disease ever comes back, then it's the same VDJ sequence that's specific to the immunoglobulin expressed on that particular B-cell lymphoma. I think that this is really interesting, and this really is moving up to being studied in upfront studies. So these are over 100 patients with diffuse large B-cell lymphoma, and this is their interim CtDNA status, whether it was positive or negative. And you can see, and this is survival. So you can see that in the middle of treatment, if people had a positive CtDNA assay, they had a much worse survival of about 50% versus over 80% if their CtDNA was negative in the middle of treatment. But this has not been proven prospectively, but I think that looking at this, and once we have data back from prospective studies that have looked at this prospectively, this is an assay that we will be using as an adjunct to imaging in the middle of therapy and also at the end of therapy to determine if somebody's in complete remission, and then following patients who are in remission with CtDNA assays compared to CT scans and PET scans, which are not very sensitive and sometimes cannot be very specific, especially PET scans. I haven't really talked a lot about HIV-associated lymphomas, but this is something that we're very interested in here. It's a real unmet need in the DC metropolitan area. We've got a very high rate of HIV and high incidence, obviously, of HIV-associated lymphomas. And this just shows you that the biology of HIV-associated lymphomas has really changed in the antiretroviral era compared to the time when we didn't have antiretrovirals. And that's been really good. It's pushed lymphomas towards much more curable lymphomas. And most people with aggressive B-cell lymphomas who are HIV positive, they have a similar outcome to patients who are HIV negative if they're treated in the right circumstances. But unfortunately, if we look at outcomes in an area like DC, people with HIV lymphoma do not have very good outcomes, and much lower than the outcomes that we see in clinical trials. And this is something that we're very interested in looking at and understanding more. And also a big part of that is better inclusion of people who are HIV positive in clinical trials, and people with HIV-associated lymphomas in clinical trials. Unfortunately, if you look at novel drug development, the vast majority of studies using new agents will not allow people who are HIV positive to be enrolled on those studies. And I think that's problematic because these people do very well. I mean, they are, in terms of their immune function, when they're on antiretrovirals, they can tolerate treatments very well. And obviously, as we develop new treatments, if there are advantages, it's important to have that population included. And also, if there are specific toxicities, we need to see those as well. So a few years ago, I worked with a group of people, and we worked with the FDA and came up with recommendations for inclusion of this group in clinical trials. And I think that a lot of work is moving forward at the moment in terms of making sure that continues to happen. So this is something that we're particularly interested in. I think here we're really, really interested in improving outcomes for AYA lymphomas and better understanding those. I've talked a lot about the biology of diffuse large B-cell lymphoma, but in AYAs, again, it's a whole other discussion, but there's no doubt that pediatrics and young adults with diffuse large B-cell lymphoma have got very different types of tumors. And I think we have not done a very good job in completely understanding that and really focusing on that group to look specifically at their biology and compare it to the majority of people with diffuse large B-cell lymphoma. So just to conclude, there are a spate of new agents and strategies, as you can see in B-cell lymphomas. We, I think, have finally, moved on to perhaps an alternative to R-CHOP, adding polatuzumab, but we have to see the full results of the study. But initial results say that in the Polaric study, adding polatuzumab to R-CHOP was associated with a better survival compared to R-CHOP alone. And there are a number of other studies that will be read out in the coming months that hopefully will augment curability compared to R-CHOP. And then in terms of future directions, the role of MRD and circulating tumor DNA is certainly emerging, and I think that that's very exciting. And in upfront studies, MRD is incorporated into all upfront studies. So when the results of these studies are reported, it will be very helpful to see what the role of MRD is and how it can be helpful. So with that, I'm happy to answer any questions.